You're listening to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is April 16, 2012, and I'm your host, Dr. Jay Portnoy. Our topic today, immunologic pulmonary disorders. Our presenter is Dr. Hugo Escobar. He's in the section of pediatric pulmonology at Children's Mercy Hospitals and Clinics.
So very simple. The objectives are first to describe the main defense mechanisms that the respiratory system has to defend itself from the environment, and two, just discuss a few diseases that I think are important for you guys to kind of be aware that either are very common or have a very significant immune component, and it's just important to kind of talk about the pathophysiology and the clinical presentation and the radiological findings. In pulmonary, we depend a lot on radiological findings. So first, the respiratory system, is other than the skin, is actually one of the ones that is more exposed to the environment, and it has two main defense mechanisms. One is called the innate system, and the second one is the adaptive system. So the innate system requires no previous interaction with the environment, and it's ready to respond immediately. I think it's one of the most important ones, and it's one of the most underestimated ones, because it's a given that pretty much everybody has it, but not everybody has it. So the first part is the upper airway, and the upper airway, in the upper airway we have the nose with their hairs, the epithelium, and also all the different kind of tortuous curves that it has, and it just helps to filtrate particles that are very large. These particles are above the 10 micrometers. When we have problems that with this area, then we're going to have increase in respiratory problems. And then I guess a good example is a kid that has chronic congestion on the nose or nasal obstruction and is a mouth breather, so you bypass the nose. And the example that we see more often is a kid with a tracheostomy. And with a tracheostomy, you completely bypass your upper airway, your nose, your mouth, and this kid is exposed to a lot of the environment without the protection, the moist or the warm air that the nose provides. Then we have, in the lower part, we have the tracheobronchial tree, and in the tracheobronchial tree, we have what we call the respiratory escalator. And in this area, we're going to filter particles that are between 5 to 10 micrometers. And one of the most important, it's pretty much, it has three different systems. One is the cilia and the mucus layer. And in the problems in the cilia and the mucus layer, like for example in ciliary dyskinesia or cystic fibrosis, are going to retain mucus. This retained mucus is going to give you more infections and more bacterial colonization. The other important part is the mucus itself, and the mucus itself has one of the most important components is the mucus proteins. The two most important mucus proteins in the respiratory system is MOC5AC and MOC5B. And these mucus proteins, the amount that they are or the proportion they are going to change the characteristics of the mucus. In addition to that, these proteins can also bind into organisms, kind of neutralizing them and protecting the airway. And then the smallest of all the particles that are less than 5 micrometers, they can actually penetrate deep into the alveoli. And these particles them are going to produce products inside of the alveoli. But in the alveoli, the one that protects or cleans alveoli are the alveolar macrophages. And problems in your macrophages are going to give you different problems. And in the pulmonary system, the main problem with the macrophages is going to give you diseases like, for example, alveolar proteinosis. Then we have some cells or molecules that are kind of in between the innate and the adaptive system. And you guys know more about this than me. So you have your dendritic cells that present antigens, the natural killer cells, neutrophils, gamma delta T lymphocytes that don't require any previous presentation, are important for mycobacterial infections. And then very important substances like pattern recognition receptors, your toll-like receptors, mannose-binding proteins, IgA, defensins, lactoferrin, and then surfactant. In surfactant we have 4 main surfactant proteins: surfactant protein A, B, C, and D. And surfactant protein A and D are very important as trying to defend the alveolar area from organisms. Surfactant protein B and C are more important in decreasing the forces from water and try to decrease, improve pulmonary compliance. So when we talk about little baby that needs surfactant, or when we talk about compliance, we talk about surfactant protein B and C. When we talk about defense, it's more surfactant protein A and D. Then this part is the one that you guys know very well. So you have your the one that requires preview presentation, and it is going to require more than 4 days to start acting. And the most important one, as we said, is like you have your macrophages, your dendritic cells, and your lymphocytes, and all of these are going to create different types of response. So we can have like a Th1, Th2 response, which you guys know very well. And specifically for the respiratory system, we have now described a Th17 response. And the Th17 response, it's an important response because we deal with a lot of chronic neutrophilic problems, and IL-17, it's a very important interleukin that mediates, activates, and recruits neutrophils. So it's kind of a response that has been associated with diseases like cystic fibrosis or chronic bronchitis. And we have found out that IL-17 is dependent of toll-like receptor 4 in the respiratory system. So it's a mediator for this type of inflammatory process. We have, so the first case, it's a 5-month-old boy who had a history of infantile wheezing, asthma, and started with fever, increasing work of breathing, came to the ER. In the ER, he was found to be hypoxemic. He was diagnosed with a bronchiolitis type picture. They did a respiratory panel, and they found that he had an infection with adenovirus. He stayed in the hospital for about 2 weeks, but he was requiring oxygen all this time. He looked great, but he was still hypoxemic and having some wheezing. He was given systemic corticosteroids for 5 days, bronchodilators, and the wheezing or the hypoxemia never changed. So we thought that he just needed more time. He was sent home. He came back about 2 months later, and he was still hypoxemic on room air, needing about 1 liter of oxygen. He was still having some wheezing. On exam, his oxygen saturation was 2 months later was 88% with 1 liter of oxygen. He was tachypneic, and he had expiratory wheezing. His CBC was normal. He had a basic immune workup that was also normal. We got a chest X-ray, and in the chest X-ray you see the very significant hyperinflation. You see increasing the AP diameter, and you see that his diaphragms are pretty much completely flat. We got a CT scan, and CT scan, this is an expiratory film. We did an inspiration and expiration. Expiratory films help us to identify areas of airway obstruction. And as you can see, you have an area that is very dark here, which is hyperinflated, with an area that is a little bit hypoinflated. So this kid had areas of hypoinflation, hyperinflation, which are suggestive of reactive airway disease or even bronchiolitis obliterans. So this, you can barely see it. This baby did infant lung function test, and as you can see, the expiratory force flow, it's very scooped here, showing airway obstruction, and his functional residual capacity was at 214% of predicted. So it means that there is a significant residual volume increase with significant air trapping. So based on his pulmonary function test, CT changes, wheezing, and an oxygen requirement of more than 2 months, he was diagnosed with, and the history of adenovirus infection, he was diagnosed with post-infectious bronchiolitis obliterans.
How do you do the PFT in a family?
We do, they require sedation. We do sedation with chloral hydrate. They, once they are placed under sedation and they are asleep, we put a vest on them, and we put a face mask till it's tightly fitted in there. Either we squeeze their lungs to try to force an exhalation, or we inflate the lungs and then we squeeze the lungs to simulate like a vital capacity and a forced exhalation.
They're in like a little box.
We do the so
Minneapolis they have like
so the little
a little box.
so the part of the vest shows it's for flows to simulate spirometry. The part of the box is to measure functional residual capacity. And so in the box is like being in a telephone booth, and you can actually measure lung volumes, and that's how we measure the FRC when the baby's on the box. So and when you cannot do pulmonary function tests and you're feeling doubt, then what you have to do is a lung biopsy to diagnose bronchiolitis obliterans. But in this baby with all the history that was typical, and in general he was doing well, just still having some hypoxemia and tachypnea, we were able to diagnose him without doing a lung biopsy. So bronchiolitis obliterans is a severe fibrosing form of a chronic lung disease. So there is a significant lung injury, and the way the body responds to it is by having airway bronchial fibrosis and constriction. In children, the most common etiology is adenovirus. In adults, there are other forms that are more common, like occupational problems, hypersensitivity, pneumonitis, or even connective tissue disorders. When when patients post-transplant, specifically for lung transplant or bone marrow transplant, present with chronic respiratory problems with airway obstruction, airway trapping, and pulmonary infiltrates, and it is called bronchiolitis obliterans syndrome. Bronchiolitis obliterans syndrome is the main cause of morbidity and mortality in post-transplant patients. So in general, post-infectious, the most common one is adenovirus. Then the one that we know and why bronchiolitis obliterans is better known is in transplant patients, specifically for lung transplant, or the ones that had a heart or bone marrow that they developed a graft versus host disease. And a newly described that is actually becoming, you're seeing more and more case reports is after Stevens-Johnson syndrome. So as we said, initially there is a significant insult to the respiratory system and specifically to the airways. Then this is going to release IL-6 and IL-8 in the BAL, creating a significant inflammatory response. And then there is a significant thickening and scarring of the airway. So this is an airway, and what you see here is this is muscle. So as you remember, like between the muscle and the epithelium, there is a very thin layer of a submucosa there, but all of this is all thickened and full of inflammatory cells and fibrosis, and this is what is left of the lumen. You can actually see some of the respiratory. This is the only thing left from the respiratory epithelium here. So this bronchi is very thick, and there is pretty much no lumen there. When in addition to obliteration of the bronchi, there is also involvement of the alveoli. That is what is used to be called bronchiolitis obliterans with organized pneumonia, that now is called cryptogenic organized pneumonia. This is a disease mainly of the distal airways, and that's why you don't see cartilage in this image here. Because if it was a bigger bronchi, then you will see cartilage either here or here on the side, but you don't see it because it's mainly a disease of the smallest of the airways. The clinical presentation, so typically we're going to have a history of either adenovirus or a patient status post-transplant, or a patient with an hypersensitivity pneumonitis who has persistent tachypnea, hypoxemia, has persistent expiratory wheezes, may have crackles. There is signs of airway trapping. So in the X-ray, you're going to see increase in the AP diameter with hyperinflation. In the CT, you may see areas of a mosaic pattern with hyperinflation and hyperinflation, and I think we have an example later. In pulmonary function test, there is a significant airway trapping, so you see that your residual volume is very increased, and this is a normal patient. So your residual volume is very increased due to airway trapping. The vital capacity is very small, as you see here, and there is significant scooping of the expiratory loop. So your ratio is going to be very decreased, your FVC is going to be decreased, and your FEV1 is going to be decreased. FEF 2575 is going to be the one that is going to be the greatest decrease because it's mainly a disease of the small intestine. If you guys have any questions, just interrupt. So we talk about the chest X-ray, and this is a typical CT of a patient with bronchiolitis obliterans. This is an older patient that you see these areas of hypoinflation with hyperinflation, and this is what is called a mosaic pattern. In addition to that, I think this patient may have some areas of bronchiectasis too. But you see that this is what is called the mosaic pattern, that you see wider areas with darker areas. 1/3 of patients that develop bronchiolitis obliterans, instead of having big hyperinflated lung, may develop the opposite, which is a small hyperlucent lung, and that is called the Swyer-James syndrome. And the gold standard for the diagnosis is lung biopsy, where you see partial of complete obstruction of the terminal respiratory bronchi by a very thick fibrosis and inflammatory process there.
Can you have a normal chest X-ray?
I would say yes. Sometimes the X-rays are not great for this, especially in children. And so, for example, in post-transplantations, more than going by X-rays, we go by CTs. And some of these changes can be very subtle in the very distal airways. So even just a regular CT, if you do a regular CT, you may miss it. If you really are suspecting bronchiolitis obliterans, then you have to ask for an expiratory CT, or both, inspiratory and expiratory CT, which not necessarily high resolution, just a regular CT, but at least inspiratory and expiratory, you have to ask for an expiratory CT. Because just if you don't during the inspiration, you may miss all the areas of obstruction.
We saw a 60-year-old who had a viral infection, and then she developed a bronchiolitis picture, but she had normal chest X-ray, and her CT was normal, although we did not have her.
Yeah, so that's for our patient actually. If you see, he says you have to ask for an expiratory right here. This is the expiration. Because if you don't, and you can actually see it very nicely during the inspiration, it may look completely normal, and during the expiration, you start seeing these images. So, and with some of our post-transplantations, when we are really suspecting this, we always ask for that. And even if we get a normal CT, but they tell us that they didn't do an expiratory film, we go back. Yeah. So treatment is mainly supportive. Most post-infectious bronchiolitis obliterans is non-progressive, so we do adequate nutrition, immunizations, we want the kid to grow, airway clearance as needed if there is increase in mucus production, as much oxygen as they need to prevent hypoxemia. And some kids may have a significant response to bronchodilators, so in those kids we may use bronchodilators and inhaled corticosteroids, but in the ones that don't respond to bronchodilator, there's really no need to give them albuterol. There have been some case reports of and actually I think it's now more used, and the patient that we have, he's on chronic azithromycin, and we use azithromycin 3 times a week, and this is extrapolating from other chronic obstructive problems like cystic fibrosis or chronic bronchitis, where we have found that it helps as an anti-inflammatory and mainly decrease IL-8 production. The use of systemic corticosteroids is not very well known. In some cases they say that in the acute process may help, but in general, once you have it, I think it does very little and we don't use it. And in patients with severe progressive disease, they are going to require them lung transplant.
What if they were like a previous lung transplant patient that developed it? Do you think that helps to transplant them again?
Yeah.
Yeah.
So some patients get 2 transplants.
Okay. Yeah. And that they just don't develop it again.
I think I don't see why not. I think there is still a risk of doing it,
okay.
But some patients they we transplant. Yeah. And but I think this is very patient specific, but it's not a contraindication. So prognosis. So patients with post-infectious bronchiolitis obliterans in general do very well. So they get the acute process. They have the persistent oxygen requirement that is non-progressive. And as they grow older and the lungs heal, then the disease is going to resolve. but in patients with post-transplant for bone marrow or lung, they have persistent airway obstruction, and this is how these patients end up getting into trouble and actually dying from this problem. Let's talk a little bit about acute respiratory distress syndrome, ARDS. And so ARDS is another way of a severe response to a lung injury that can happen through many different etiologies. The most important ones are sepsis, aspiration, severe trauma, massive transfusions. So when they have looked at different patients that have ARDS, they have the main question is patients that have ARDS because the cause is coming from the respiratory system, are they more at risk and they do worse than the others? And what they have found is that it seems that that's the case, but I mean, I don't think that that is completely clear, but it seems that patients that the main reason why they went to ARDS, if it was a pneumonia or a massive aspiration or something that is related to the respiratory system, they in general have a worse prognosis than the other patients. And in general, kids do better than adults. So the patient starts presenting with an acute episode of tachycardia, hypoxemia. They have cyanosis, and in the physical exam, they mainly have crackles. In the initial blood gas, there is a pattern of hypoxemia. With, they have tachypnea, so they end up blowing some CO2, so they may have respiratory alkalosis. And one of the indicators of how severe your process is by having a big gradient between the amount of oxygen in your alveoli and the amount of oxygen that is going into the arterial system. So your alveoli arterial gradient is very elevated. So why is the gradient so elevated? And it's because initially you have your nice alveolar epithelium here with the pneumocytes type 1 here. This is a pneumocyte type 2. And you may have a 1 or 2 alveolar macrophages in here, and just the alveoli is wide open. But then when you have your inflammatory and your injury, you enter in your first stage, which is the exudative stage. And during this one, there is epithelial damage with a lot of inflammatory substances coming, and also inflammatory cells, and mainly IL-1, IL-6, and IL-8. A lot of neutrophils are coming into here, and they end up releasing all their inflammatory process. So you get a lot of airway damage, which pretty much blocks the alveoli. And when you block the alveoli, and in addition to that, all of these substances are going to inactivate surfactants, this alveoli is going to collapse. And if the oxygen cannot come in here, you still have blood flow here, so you just increase your shunt, and that's why your gradient between the alveolar oxygen and arterial oxygen is so marked. Then once you pass your exudative stage, you go into the proliferative stage. And it's called proliferative because once you have all destruction of the epithelium, the pneumocytes type 2 start proliferating, start multiplying, and from the type 2 you differentiate the type 1s, and the patient starts to heal. The patient can go in one of two directions. One, the patient can heal well with the pneumocytes differentiating into type 2 and type 1 and heal, or it can go into fibrosis. So the third stage is the resolution, if the patient does well and heal fine, or fibrosis with severe restrictive lung disease, if there is so much inflammation and damage that the patient is going to have permanent problems for life. The diagnostic criteria has to be an acute disease with something that is going to trigger it. We talk about the severe arterial hypoxemia. So when there is the hypoxemia is not marked, it's called acute lung injury. So this is the milder form of ARDS, and when it is very severe, it's called ARDS. And we mainly go by the your pressure of oxygen in a blood gas in the arterial system divided by the amount of oxygen that we're giving the patient. So for example, if we have a patient who has an arterial pressure of oxygen of 50, he's intubated and has an FiO2 of 90%, he's going to give us a ratio of 55. So even though this patient is just on 50% oxygen, I'm sorry, he's on 90% oxygen, this patient is going to have very severe disease and he's going to be in ARDS. And in general, if you have somebody on 50% oxygen and your pressure of oxygen is 50, you're going to be pretty much in ARDS. That's what, 50 divided by 50, that's 100. On the chest X-ray, this is a typical X-ray where you're going to have diffuse pulmonary infiltrates, and you can actually see some bronchogram here. And it's very important that you need to rule out that there is heart problems. So all of this is not due to the heart as heart failure. This is due to the lungs or some type of a systemic inflammatory reaction. And what are the things that have proven that help in ARDS? Mainly supportive treatment with mechanical ventilation with low tidal volumes. So we now do about 8 to 6 mLs per kilo. And the idea is to try to ventilate the patients in this area when we are more compliant, not let the patient collapse the lungs, because once you collapse the lungs, you require high pressures to reopen it, or not overinflate, because then you can just break the alveoli. So we try to ventilate the patients around this area, and to ventilate the patients in this area, we also used a PEEP, very generous PEEP, and we try not to overventilate, so we have permissive hypercarbia, so we can actually tolerate pH of 7.3 without any problem. This is the second case. This boy is a 16-year-old male who had an 8-week history of recurrent fevers. He has lost a significant amount of weight during this period of time. He has dry cough, chest pain. He's really not feeling very well. He had a CBC with 9,000 WBCs and 17% EOS. His set rate was 72. So when he came to the hospital, he had a chest X-ray done, and in the chest X-ray you can see here he has bilateral pleural effusions. You don't see really much of infiltrates in the lung. They look clear other than that. So before this, he was actually given antibiotics by the primary care physician without any improvement. He had an immune workup. Everything was fine except for the rheumatoid factor that was very mildly elevated. He was seen by ID, and a very extensive ID workup was done, and it was completely normal or negative. They actually looked for stool, ova, and parasites, and it was negative, CMV, EBV. Because of the pleural effusions, the patient got, the fluid was tapped, and he had a normal pH, but he had very significant inflammatory cells with 90% polys, and again, he still had some eosinophilia, and the LDH was very significantly elevated at 2,000. Based on this elevated LDH, CT scan of the chest was done. On the CT, he had this mass here in the lung with this inflammatory halo around it, or ground glass halo here. And so at this point, the differential diagnosis was either the patient had an eosinophilic pneumonia or had a type of parasitic infection. So we went back and we talked to him. We tried to get more history, and he admitted that he played. He said that he played, but he also ate some raw crawfish. And Paragoniomyces is actually endemic to Missouri River, Arkansas, and all of this area. When we think about Paragoniomyces, everybody thinks of Asia, and nobody knows that it's actually endemic to this area. And there have been some case reports, 3 or 4 case reports from Paragoniomyces in this area. We sent the test to the CDC, and he was positive for it. He was treated with antibiotics, and he cleared this. So it's actually it's something that we're not really aware that is here very close to us. So eosinophilic pneumonias. Eosinophilic pneumonias is a group of diseases that present with pulmonary infiltrates and eosinophilia. The eosinophilia can be either peripheral or it can be on bronchoalveolar lavage. And kind of the most common diseases are allergic bronchopulmonary aspergillosis, Churg-Strauss syndrome, that now is called allergic granulomatous meningitis, tropical eosinophilia with Ushuaia bancrofti, can be drug-induced. You can have acute or chronic eosinophilic pneumonias, and Loeffler syndrome, which most of the cases with Loeffler syndrome were found to be parasites with ascaris. But here I think we need to take into consideration that the Paragoniomyces is endemic to the area where we live. And here we just see lots of eosinophils with some alveolar macrophages. Just remember that the macrophages are the most important cell in the alveolar part. So ABPA. ABPA is a hypersensitivity reaction that is followed by the colonization and sensitization by Aspergillus. The most common is Aspergillus fumigatus, but you can be sensitized to other types of Aspergillus or even to Candida. It mainly affects patients that have an atopic component or a chronic lung disease problem. So the most commonly seen in patients with asthma or in patients with cystic fibrosis, and we see it very often in our cystic fibrosis patients. I've said that it's up to 15% of cystic fibrosis patients can have it. So the spores are very small, so you guys remember that less than 5 micrometers, it can penetrate deep in the lung, pretty much to the alveoli, and this is why these things happen. So the spores can penetrate deep in the lung, and once they are inside of the lung, it's nice, it's moist, it's warm, they germinate, and they just they go inside of the tissue of the cells, and they germinate, and that's when you become more sensitized. I'm sorry, it's kind of small. So not everybody is going to be. I mean, Aspergillus is everywhere, and we inhale Aspergillus all the time, but not everybody that has asthma or cystic fibrosis develop it. So what they have found is that there has to be a genetic predisposition to develop sensitization and to Aspergillus, and they have found expression of HLA-DR2 and DR5 as being a risk factor to develop ABPA, polymorphisms of IL-4, and also polymorphisms of the IL-10 promoter put you at risk of develop ABPA. So you have your genetic predisposition, and you inhale Aspergillus fumigatus, which is everywhere, and then it germinates inside of your airway, and two things happen. One, the antigen-presenting cells, the dendritic cells, present this, and they create a Th2 type reaction, and then you become sensitized. But at the same time, the immune system in the body tries to kill the Aspergillus. The Aspergillus reacts to it, and it releases the cytokines and chemokines, and all of this creates an inflammatory and an early and late phase reaction. So there is also a type 3 reaction component, and then you end up with having all of the clinical, and laboratory findings of ABPA. So similar to the case that we saw before, this is a mucus layer that is you can see that is full with eosinophils, and you don't really see much of a lumen there. And then you see lots of the Aspergillus here in a mucus sample. So what are the clinical manifestations? The patients can have small or very minimal symptoms or very severe symptoms. So it can present from just what it looks like a patient that has difficult to treat asthma, and you give regular asthma treatments, and they just keep coming back to the ER, and they keep giving 5-day courses of prednisone. He gets better for 2 weeks, and then 2 weeks later gets sick again, and just like that for 3 or 4 months, and multiple courses. It's just not presenting as a typical asthma patient. Or it can be actually more severe with cough, wheezing, fever, and significant symptoms that the patient actually looks very sick. On chest X-ray, there are some typical findings and some general findings. Mainly, the patient is going to look like the patient has an obstructive problem with hyperinflation, but there is significant bronchiectasis and mucus impactions. So it has described that the X-ray may look like the tram lines. So you see your main bronchi, the bronchi walls are very, very thick, or it's called a toothpaste or glove finger. So you have your thick bronchi, and inside of the bronchi there is a very thick mucus layer. And so at the beginning it may look mainly like an obstructive problem, but if in advanced diseases or diseases that were untreated, it can actually progress to severe fibrosis with honeycomb. So these are some examples of CT patients with ABPA. So as you see, it has very significant bronchiectasis, but the bronchiectasis are centrally in the central area. You don't see much of peripheral bronchiectasis. And you see very significant. This is mucus impaction in an area of bronchiectasis. Mucus impaction, mucus impaction, mucus impaction, and this is all mucus in there. For the diagnosis, there is no one test that is going to just tell us yes or no the patient has ABPA. So we go by the major minor criteria. And the major criteria, the patient has to have either asthma or a history of cystic fibrosis. There are migratory pulmonary opacities, which is just mucus impaction. The skin test positive for aspergillus, which is a type 1 reaction. There is a significant eosinophilia on the CBC. The patient has precipitating antibodies in serum. The IgE is typically above 1,000. As long as the patient is off of steroids. In patients with cystic fibrosis, we consider the diagnosis if the IgE is above 500. On CT or chest X-ray, there are evidence of central bronchiectasis, and the specific aspergillus IgG and IgE are elevated. Then we have the minor criteria, which is aspergillus in the sputum. We grow aspergillus in the sputum in many patients that are healthy, so that's why it's part of the minor criteria. Brownish mucus plugs. So the minor criteria is I think it's just supportive criteria, but we see it's really non-specific. And one of the things about asthma patients is that if they can be classified or divided in between ABPA with bronchiectasis or ABPA without bronchiectasis. And the ones without bronchiectasis, they do very well and they tend not to recur. You treat them once and that's it. The ones with bronchiectasis are at risk of recurring more and might be the patient that you end up treating with, if needed, with 2 medications. So the main treatment is systemic corticosteroids with a long taper, and in the patients that recur, and then you may add an antifungal medication, which it can be either itraconazole or voriconazole, and there is some debate on how is this medication mainly help in ABPA. Some people think that it actually decreases, kills the fungus, and it decreases the burden and the allergic component to it. Some people think that itraconazole or voriconazole actually interfere with the metabolisms of systemic corticosteroids, so you're actually elevating the dose of the systemic corticosteroid in the blood. There are some reports of monoclonal anti-IgE antibodies to help in ABPA, and actually there are more and more reports, and I think we're going to be starting one of our patients with Soler because the patient also has atypical mycobacteria, and we don't want to give him too much steroids. So we'll see how that goes. And as we said before, the prognosis is good, especially in the absence of bronchiectasis. But most patients with cystic fibrosis, they become steroid dependent and they require treatment for many years. Continuing with the eosinophilic pneumonias, allergic granulomatosis and angiitis, or Churg-Strauss syndrome. So it's a disease mainly a vasculitis of the small vessels, and it involves multiple organs like the skin, like the nerves, like the GI system, like the lungs, and it is mainly characterized by a patient that has been having asthma for several years. They say that most patients have had asthma for at least 10 years. So it's going to be a disease that is going to be seen in older patients, or occasionally can be seen in kids. They have peripheral eosinophilia of more than 10%. They have nerve problems like neuropathy. They have nodular pulmonary infiltrates, and they have multiple sinus problems. And the most common skin presentation is palpable purpura. As we said earlier, the asthma starts early in the course, and most patients have a long history of asthma before the other symptoms present. And then it is unclear the role of the anti-leukotrienes. Multiple years ago, it was noticed that some of the patients that were started on anti-leukotrienes, they develop Churg-Strauss syndrome, but when they have looked at the different studies, it is more likely, some people thought that the medication would induce the disease, but what it is more likely is that once we start another medication to control the asthma, it allows you to either lower your systemic corticosteroids or lower the high-dose inhaled corticosteroid, and this is what in reality triggers it was like hidden there or control by the treatment that you were doing before, and now when you started your anti-leukotrienes, then it just allows to flare up. This is an example of a patient with palpable purpura, CT of the sinuses with very significant, you don't see pretty much any lumen here, a level here. And then you see, this is the typical pathology with granuloma formation. That is a very mature, poor granuloma formation with eosinophils, and the eosinophils are mainly outside of the blood vessels. So I will discuss that. So it's for the diagnosis, there is some laboratory tests and imaging, and similar to ABPA, we have kind of a criteria for it. So in up to two-thirds of patients can have P-ANCA positive, and the P-ANCA is mainly related to myeloperoxidase. A chest X-ray has bilateral patchy alveolar infiltrates, and as we said in the biopsy there is eosinophilic pneumonia with necrotizing vasculitis and granulomatous formation. So for the criteria, if you have 4 or more, the sensitivity is up to 85% and the specificity is 99%. And the criteria then is asthma, eosinophilia more than 10%, mono or polyneuropathy, migratory pulmonary nodules, paranasal sinus abnormalities, and then finally a biopsy that is going to show that the patient has extravascular eosinophilic inflammation with granulomatous formation. Treatment. So the treatment is very complex because a lot of patients that have Churg-Strauss actually have had multiple remissions, but it also seems that with newer treatments, remissions have decreased. So initially, you have your induction therapy, where you use systemic corticosteroids, similar to ABPA. You need systemic corticosteroids for a long time. Then you do your maintenance of remission. And in the induction, if the patient has neurological problems or has cardiac involvement or is a high risk for remission, then you start the patient also on cyclophosphamide. For maintenance of remission, mainly people have been using azathioprine, but methotrexate also has been used to try to decrease the dose of the steroid. Relapse can happen in up to 35% of the patients. Up to 80% of the patients, but this has actually in the newer reports, relapse has been lower than before. And but most of the patients continue on systemic corticosteroids for many years. There has been some case reports of humanized anti-IL-5 as trying to decrease the dose of the steroids, and the main complication of Churg-Strauss is actually cardiac dysfunction, and this is the leading cause of mortality in patients. So in patients that already have some degree of cardiac involvement, those patients are really going to require cyclophosphamide at the beginning because you need to try to control that. I have a third case. This is a 6-year-old boy who presents with a 2-month history of dry cough, also some weight loss. He has had some recurrent fevers. He was given some antibiotics and bronchodilators and antitussive medications by his primary care provider, but there was really no improvement with that. On physical examination, he had some tachypnea. He was hypoxemic with a low oxygen saturation. And on exam, he had bilateral crackles. He had a chest X-ray done, and the chest X-ray you cannot see the diffused nodular infiltrates everywhere in the lung. Like everywhere you see all of that haziness. Very, very reticular, very interstitial. You don't see much airway trapping here or hyperinflation. So the kid had a CBC and CRP that they were within normal limits, got ID workup that also was completely normal. He had a thorough and specific IgE against the common allergens by RAST, and it was all negative, and it was noticed that his IgG was a little elevated. So based on the chest x-ray, there was some more history taken, and and also because of the persistent hypoxemia, bronchoalveolar lavage was done with bronchoscopy, and the kid has some. When we do a bronchoscopy, pretty much the only cells that we see are macrophages. So when there are lymphocytes or any other type of inflammatory cells, it kind of guides us that there is a significant inflammatory process. And on him, the majority of cells with lymphocytes, and he had also some granulocytes. And it was noticed that the CD4-CD8 ratio was decreased. So with the decreased ratio and the interstitial findings on the chest X-ray, more history was taken, and the kid started having symptoms after he had spent about 2 weeks in a farm where he was exposed to multiple farm animals, including some birds. So precipitants were done, and they were actually elevated for pigeon, Aspergillus, fumigatus, and strongly positive for high and perikids. This kid actually had a lung biopsy done, and it had inflammatory infiltrates on the terminal bronchi. But he, different from the bronchiolitis obliterans, he also had interstitial pneumonitis with some multinucleated giant cells. So this with the history was compatible with hypersensitivity pneumonitis. So hypersensitivity pneumonitis is a mainly lymphocytic and granulomatous inflammatory process that involves the alveoli and the interstitial spaces. So all the other diseases that we talked before, those were airway problems. This is more an alveolar and interstitial problem. And this inflammatory process of the alveoli and the interstitium is in response to inhalation of organic antigens. The signs and symptoms start after the patient has been having some significant exposure to an agent that is known to produce hypersensitivity pneumonitis. But the same as with ABPA and Aspergillus, not everybody that is exposed to a known agent is going to develop this disease. So they have looked at people that has been exposed, just 7 to 15% of people that is exposed to a known agent that produces hypersensitivity pneumonitis actually develop it. Depending on the level of exposure, the amount of the antigens, and the patient susceptibility, they can present as an acute, subacute, or chronic form. These organic dusts are very, very, very small, and that's why they can penetrate all the way to the alveoli and produce alveolar problems. Once they are there, they go to the areas of the lung that are more ventilated. So the areas of the lung that are more ventilated are the lower parts of the lung. And that's why initially we're going to see that the patients have interstitial infiltrates in the lower parts of the lung. There is a sensitization to the antigens in that part, and with repeated exposure they end up having alveolitis with recruitment mainly of CD8 cells. So that's why on the bronchoalveolar lavage the CD4-CD8 ratio was low, because it's mainly CD8 cells. Different from diseases like a sarcoid, for example, where the CD4-CD8 ratio is elevated. So there is a specific production of precipitated antibodies to the thing that is causing the disease. So in this you have to be actually very specific, because we need to find out exactly, for example, what type of bird the patient was exposed, because you may not develop random old birds. Some birds have a specific antibodies that you need to actually test for that bird. And we talk how initially these antigens are going to go to the areas that are more ventilated, which is the lower lobe. But with chronic persistent exposure, then the patient is going to have problems in the upper lobes too. And one of the thoughts is that there is some, in the upper lobes, because there is lower perfusion, there is less macrophages, and those areas are, anything that you inhale is going to accumulate more, and that's when you end up having a lot of problems in the upper lobes. The most common, the list is very long, and I'm pretty sure that it's going to keep growing, but the most common ones that we see in children is birds. In this area, we have all the, there's a lot of farming, so it is also farmer's lung is very common. There is, in the south part of the state, there is, we have had several patients. I haven't had a patient that has hypersensitivity pneumonitis to this, but we have had several families that whose parents work in, with wood, and they actually work in the forest trying to cut wood. And to take into account, it also can present in patients with dehumidifiers, and so in patients they're very common at homes, and we always have the same question: do we need a dehumidifier? Do we need a humidifier? And all of those things. So depending on the presentation, the signs and symptoms can vary. We have the acute, subacute, and chronic. The acute presentation, the patient has symptoms 4 to 6 hours after exposure. You have symptoms that are similar to like a flu-like infection with fever, cough, shortness of breath. They have chills. They just don't look well, and they look like they have the flu. Physical exam, they have crackles. They may have hypoxemia. When we do a lung function test, there is mainly a restrictive problem. Remember, this is mainly a disease of the interstitial parts, not the airway. They also behave like if they kind of have the flu with the elevated WBC counts. They may have eosinophilia. In the bronchoalveolar lavage, in this in the acute phase, they mainly have leukocytosis. And in the chest X-ray, they have a chest X-ray similar to the one that we saw with mainly interstitial infiltrates in the lower parts of the lungs. Treatment for this one is mainly just to avoid exposure. And so these patients come to the hospital, and then in 2 days they are fine, and you wouldn't do anything for them to just get better on their own. In the subacute, it is more the exposure. The patient has repetitive exposure for days, and the symptoms are a little similar, but they don't look that sick. But they have more chronic problems. So they have anorexia, they have weight loss, they have dry cough. They also have crackles and a restrictive pattern. And here the difference is that in the bronchoscopy, the ratio is going to be decreased at this phase. In this one, it's not, because it's mainly like an acute inflammatory process with leukocytosis. These patients present with interstitial changes, but there are some exceptions that the patients may present with hyperinflation. And the symptoms improve after pretty much 2 weeks of decreased exposure. And some patients that have severe symptoms or have a severe presentation, they may require systemic corticosteroids. And then finally, the chronic exposure is a little different, because this one has a more insidious process with the chronic cough. Most of the time it's a dry cough, a shortness of breath, and they may develop hypoxemia. They may develop clogging on exam. Have very, very severe restrictive lung disease. And actually here the ratio actually changes, so the ratio is more important for the subacute. And these are the patients that are going to have also changes and interstitial changes and honeycomb of the upper lobes. And these patients may actually progress to respiratory failure and cor pulmonale if untreated. And the main treatment, as with the others, is trying to avoid exposure and, if needed, systemic corticosteroids. So we have here an example. This is mainly lower infiltrates with a diffused reticulogranular infiltrates in both faces. As you can see, the upper lobes are a little involved, but not as much as the lower parts. So you can see a good aeration here in these areas. And this is a CT with very diffused ground glass changes in both bases, just everywhere. Diffused pulmonary nodules everywhere that you look at, everywhere. And this, we don't see the airways here very well. This is a patient that actually presented with airway obstruction, so similar to the example of bronchiolitis obliterans, we see the mosaic pattern. So in some occasions, it can present as airway obstruction with a mosaic pattern, like in this example. This is a patient with chronic hypersensitivity pneumonitis. So this patient starts having upper lobes fibrosis and honeycombing, and this is irreversible changes. This patient is just there is really not much to do for this patient at this point. So for the diagnosis, biopsy is not always necessary. If you have a clear history, you have the precipitants and everything kind of matches, the patient is not exposed and improves, then you don't need to do biopsy. And actually there are really no typical changes on biopsy, and we're not really going to see the offending agent there. So biopsy can actually guide the diagnosis in sometimes just 30% of the cases. But in some cases it's necessary, especially if you need to rule out other diseases. Like for example, the girl that presented with the obstructive pattern, you need to rule out other type of airway problems. And for example, in a multi-center trial, they found that really biopsy just altered the diagnosis in like about 50% of the cases. So in the acute stages, we talk about is mainly lymphocytic inflammation, and in the more chronic is mainly fibrosis, and then you have your decrease ratio. The more things that you have that are suggestive of hypersensitivity pneumonitis, the more that you improve your diagnostic sensitivity and specificity. And actually, if you look at here, the exposure to a known offending agent is kind of like the most important thing that you need to have. So the kid grandma has birds, and every time he goes to grandma, he has shortness of breath, cough, and he just doesn't look well. And then he goes back home for the rest of the week, and he's fine. So this has happened several times. So that's kind of like a history that might be compatible with that. You have your antibodies, it's also very significant. And if the symptoms happen 4 to 8 hours after exposure, it's just very typical of that. Then the more you add up, the more that they can give you the diagnosis. If you have also chest X-ray that is typical, as we talked with the lower lobes, and when in doubt, you can always do a bronchoalveolar lavage and look at the ratio and see if it's compatible with that type of inflammation. Yeah. No questions?
Thank you.
You're welcome.
This has been an ACAAI production. To learn more about Conferences on Lyme Allergy or the American College of Allergy, Asthma, and Immunology, go to www.acaai.org. See you next time.